Hi, this is Elliot Fishman, and welcome to our latest series of talks. And this is going to be on cystic pancreatic lesions. It's one of the most important topics we deal with on a daily basis. What I'd like to speak to you about, and this will be a 5 or 6-parter, it's really a comprehensive way of thinking about cystic pancreatic lesions from detection to diagnosis to management. Where we are and where we're going is what we're really going to look at. Now, pancreatic cystic lesions are very common. We wrote this paper more than a decade ago, and on a 16-slice scanner found 2.6% of patients had pancreatic cysts with increasing age, and patients from an Asian race more likely to have cysts. At that point, there were articles in MR which made the point, 2002, almost 20% of patients had an incidental pancreatic cyst on a MRCP or MR simply done, with the point being that it's very, very common. These days, of course, we know that the better the scanner, be it CT or the better the MR, the likelihood of picking up a pancreatic cystic lesion, in fact, increases. The problem is most of these lesions are not important, but the question is, who do you follow? Who do you resect? Who do you just totally ignore? It's not a simple question. And that's really one of the focuses that we'll speak about in this talk as well. But if you look at cystic pancreatic lesions, and we're going to talk about each of these individually, there are a number of different things that kind of fit in the category. Pseudocysts related to pancreatitis. So again, history becomes very important. A patient with a history of pancreatitis or other signs of pancreatitis with a cystic lesion, statistically, is more commonly a pseudocyst. We talk about IPMNs, intraductal papillary mucinous neoplasms. These are one of the most common lesions, particularly patients over age 60. IPMNs can be a precursor to cancer, but less than 3% of all patients with IPMNs ever develop a cancer. So you have to follow a lot of patients to pick up a cancer, and it's not clear that surveillance in a patient without a family history is actually worthwhile. Then we talk about serous cyst adenomas, and I'll show you how they look. The good thing about serous cyst adenomas, although they can be very large, they're always benign. There is no malignant potential, and so if you can diagnose them, you either don't do surgery, if the patient's asymptomatic or minimally symptomatic, or if they're large enough and the patient's symptomatic, you do surgery, but knowing it's an aggressive surgery, of course, because any pancreatic surgery, be it a Whipple's or a distal pancreatectomy, is always an aggressive surgery, but at least you know you're not worrying about malignancy and there's no need for follow-up typically. We talk about mucinous cystic neoplasms. We'll speak about the age of the patient, 40-ish-year-old female. Most people feel that all MCNs should be removed because they're pre-malignant. There's been some work recently that perhaps under 2 cm, maybe just watch the lesion, but that's still not the standard of care. We talk about neuroendocrine tumors, cystic neuroendocrine tumors. The typical neuroendocrine tumor is hypervascular, and it's not confused typically with a cystic lesion, obviously. But there are cystic neuroendocrine tumors. We talk about rim enhancement. We talk about how many of these are non-functioning. And we talk about, again, how do we recognize these lesions? We'll speak about that. And then we speak about SPEN, or solid and pseudopapillary neoplasms. And again, these are tumors that typically occur in teenagers or patients in their 20s. And it's typically by about 9 or 10 to 1 female over male dominance. Now, the thing about incidental pancreatic lesions, if we say that depending on the age, 3 to 5% have incidental pancreatic lesions, again, the better the scanner, the more lesions you will see, particularly when you start calling really tiny lesions. And when patients get over age 60, it's probably in the 10 to 20% range. But most of these are just simply benign lesions. And then the question is, who do you need to follow? Do you need to follow lesions that are above a certain size, 2 or 3 centimeters? Remember, the Tanaka criteria previously said if you saw a 3 centimeter or greater lesion, you should resect everybody. We're trying to get away from that because you're resecting lots of benign lesions. And again, the incidental pancreatic cancer and incidental neuroendocrine tumor are far less common. than the incidental benign IPMN. Now, when I think about, and when I was putting this talk together, I was trying to think about how to approach it. And when I thought about it for a while, and I show a lot of these cases in conference, really you focus on three things. Lesion detection. Obviously, the most important thing is finding lesions, but then identification. Is this a serous cystadenoma? Is it an MCN? Is it an IPMN? Is it a peanut? How do you manage these patients? And the radiologist, although yes, we don't operate, we're the ones who are really determining management. So our goal is to optimize detection, optimize characterization, which allows us to make the best management decision or help us make the management decision with the patient's surgical and medical team. And I put this last line in. I think one of the biggest changes that's really going to help us in this regard, and it's coming, we're doing work on it now, other people are doing work on it, is AI. So what do we need to do? Lesion detection, optimize scan protocols. Dual phase imaging typically is better. Some cystic lesions are best seen on the arterial phase, and some are best seen on the venous phase. Scan parameters. The thinner your sections, the more likely you are to pick up small cystic lesions. And when you review the images beyond the axial plane, a lot of times, particularly small IPMNs or other small cystic lesions, are best seen on the coronal view because you don't have partial averaging like you might have on a routine axial report. 3D with cinematic is also very helpful if you're looking for small lesions where there's changes in the texture. We talk about identification. What do I look at? I look at lesion size. IPMNs are typically smaller. MCNs are in that 2 to 5 cm range. Serous cystadenomas could be as large as 13 centimeters. I look at location. MCNs, typically in the body. IPMNs, anywhere. Serous cystadenomas, more commonly in the tail. We'll look for CT signs, calcification. Appearance of calcification where it is. Center of the lesion, perhaps you're thinking about a serous cystadenoma. In the periphery of the lesion, it could be anything from an IPMN to a pseudocyst to an MCN. Could be almost any of those. The thing is probably not is an adenocarcinoma of the pancreas, right? Because adenocarcinomas of the pancreas, unless it's a tumor arising in the patient who has prior pancreatitis, you're just never going to see calcifications, although never is a bad word to ever use. We look at lesion enhancement pattern. When there's rim enhancement, you're thinking more about a neuroendocrine tumor. When there's some enhancement at the periphery with stretching of vessels, we might be thinking about a serous cystadenoma. Typically, unless there's malignancy present or high-grade dysplasia, an IPMN is not going to show any wall enhancement. So again, we're thinking about the things we need to look at. And then, of course, is what's our report going to say? Do we say the patient needs follow-up or no follow-up? In select cases, do we need to go to MR or PET? Do we need to get follow-up, be it at 6 months or 12 months? Do we need EUS and tissue sampling now? Or is the lesion very obvious, like it's a neuroendocrine tumor and the patient needs to go to surgery? Again, with the information we provide the referring clinicians is going to help reach those decisions. Now, another important thing to think about when you look at cystic lesions is patient demographics. Age, MCNs, women in their 40s, serous, more commonly age 60 to 70, IPMNs, more common after age 50, increasing after age 60. SPEN tumors, usually teenage years or in your 20s. Male versus female. SPEN tumors, 9 or 10 to 1, female over male. Clinical presentation. Most IPMNs are incidental findings. Some lesions do have symptoms, but having symptoms does not make things malignant. You can have symptoms from a large serous cystadenoma, but it's the compression due to its size that causes the problem. And of course, serous cystadenomas are always going to be benign, but being benign doesn't mean you don't have to resect them. You may need to resect them, but you're not worrying about malignancy and chemotherapy and radiation therapy and everything else that goes hand in hand with malignancy. Then, of course, extrapancreatic findings. Cystic lesions, what else could you think about? Could there be something else going on? Again, neuroendocrine tumors, you might look very specifically at the patient's liver, look for vascular liver metastasis as simply one example. So let's get started. Let's talk about pseudocysts first. Usually smooth external contour, protrusion into peripancreatic soft tissues. You may see peripancreatic stranding, and typically you're going to have a history of pancreatitis. Now, the pseudocyst will look different. If you pick up the pseudocyst during the acute phase of pancreatitis, there is more glandular edema and stranding as well as the pseudocyst. If you pick it up 4 to 6 weeks later, the pancreas may look better, but the pseudocysts may be there. Pseudocysts can have high density within them. That can be due to prior hemorrhage. They can have some model density, which could be due to prior necrosis. Usually with pseudocysts, they're well defined, typically 4 to 6 weeks after symptom onset. So a patient has pancreatitis. If you scan them in 4 to 6 weeks, you'll see a pseudocyst. Typically, when you scan patients acutely, you'll see edematous changes in the gland with fluid around the gland, but usually it takes a bit of time for a pseudocyst to develop. And then the wall of the pseudocyst can vary from pencil thin to being thicker. The frequency of pseudocysts in patients with pancreatitis can range from 10 to 20%, but the reality is most patients with pancreatitis will not develop pseudocysts. The majority of them will resolve over time. Others do not resolve, and the patients may need cyst gastroscopy, where you have to, place a drain through the stomach to drain the pseudocyst. So often they can be treated relatively non-invasively. Other patients with pseudocysts and complications, including complications like pseudoaneurysms, which often go hand in hand, those patients may need more aggressive intervention. The other thing about recognizing pseudocysts is location, most commonly toward the lesser sac, but also left anterior pararenal space or right anterior pararenal space. But the reality is we know that pseudocysts contract almost everywhere. So here's a simple example, cystic lesion about 4 cm in the head of the pancreas, seen on axial and volume rendered imaging. It has a slightly thickened wall to it. There is a faint calcification present. The vessels are well defined. If I said to you, could this be an IPMN? I guess the answer would be yes. The patient has atrophy of the distal gland and a history of pancreatitis, so pseudocyst made it a more logical approach. And here it is again, that pseudocyst pushing on the patient's portal vein and splenic vein. Here's a larger pseudocyst pushing into the lesser sac. You can see the pancreatic gland itself is atrophic. Pancreatic atrophy as a sequela of pancreatitis is a good finding and not uncommon, and can help you really be more specific as to what the cystic lesion is, but nicely shown here. Here's an unusual case. This is a cystic lesion with rim-like calcification. This patient had pancreatitis years ago, and the pseudocyst calcified. We mentioned that if you have chronic pancreatitis with glandular calcifications, the presence of a pseudocyst is more likely diagnosed when you see the sequela of prior pancreatitis. We typically think about numerous lesions that can calcify. I mentioned that before, and we'll speak about that a lot during these talks, including serous cystadenomas, including SPEN tumors, including MCN. But this case is nice. You have a nice cystic lesion. The gland is atrophic. Here it is on the coronal. Look how the rim, you can see on these MIP images, think about the pseudocyst as a circle and the entire circle being calcified. So now you're projecting through the circle, and here it is on cinematic rendering. Kind of looks like the Earth from the moon when you're looking down. But here you're talking about a pseudocyst. And again, I don't think it's that difficult to make the call. You could think about other possibilities. I have seen SPEN tumors with rim calcification, but usually not this coarse. I have seen serous cystadenomas with some rim calcifications, but not the 360 you see in this case. Okay, that's pseudocyst. Number 2, IPMNs. Usually an older population, a bit more common in men. IPMNs typically communicate with the pancreatic duct. We talk about a main duct IPMN. Articles have written that a main duct over 1 cm is suggestive of a main duct IPMN, which has a much higher rate of malignancy. The truth is, anything above 7 millimeters now, people are going to worry about. We talk about side branch IPMNs, which are the most common ones. Those are the small cystic lesions that communicate with the pancreatic duct, which may not be enlarged. If you see these cystic lesions communicating with the pancreatic duct, and the pancreatic duct is also dilated over 7 millimeters, then what you're going to talk about is a mixed type IPMN. So main duct, concerning for tumor, side branch, usually not an issue, particularly when under 3 cm, and mixed type, which is a little of both. But of course, with mixed type, you are going to be very aggressive, and it does make it difficult in planning the surgery because you don't want to do a total pancreatectomy, but this can be somewhat challenging. We talk about the fact that main duct IPMNs have a higher incidence of malignancy, and typically patients will get surgery in those situations. Now, if you look at IPMN, some of the facts, things that predict malignancy over 3 centimeters, remember the Tanaka criteria, growing over 2 millimeters per year in size. The presence of mural nodules, in a sense, always leads to surgery. The nodules may be enhancing or not enhancing, but if you got them, the patient will probably get surgery. If you have septations that are thick and surely they're enhancing, you're worrying about the patient having a high-grade dysplasia. And of course, if patients have symptoms like abdominal pain or unexplained episodes of pancreatitis, that's going to make you more concerned as well, and those patients will typically end up with surgery also. And again, I'm not going to go into this, but the whole sequence of pannins in the duct, in the gland, and that leading to the macroscopic precursors of malignancy, be it IPMNs or MCNs. And again, what you'd like to do is, of course, if you knew how to do it well, pick up these pre-malignant lesions, but not every lesion, figure out which ones are concerning and operate on the patient to prevent high-grade dysplasia, or mostly important, prevent adenocarcinoma of the pancreas. So you can see it's really a difficult way of doing things. There's a lot of work going on with pathology, a lot of work going on looking at fluid. Here was a recent article by Colte talking about early diagnosis of pancreatic cancer. And again, very similar points. Carcinoma in situ, minute pancreatic cancer under a cm, under 2 cm, and then over 2 cm. That under 2 cm is really the important area. Now remember, we talk about the radiology that 40% of lesions under 2 cm are now recognized on CT. You can see the importance, of course, is this article says 5-year survival is 30 to 40% when it's less than 2 cm. If it's less than 1 cm, it's over 50%. So again, in situ is normal survival. The key is early survival, right? If not, you end up in the category of symptomatic patients where 5-year survival, taking all comers, is going to be under 11%. So it becomes very important for us to really change this role of how we do things. You look at the bottom here, 85% of patients are diagnosed at a non-resectable stage. So 15% at best are resectable. So that's why we have such bad outcomes at 5 years. In this article by Wang, talking about early detection of pancreatic cancer, 10 to 15% of pancreatic cancers arise from precursor mucinous tumors, namely IPMNs and MCNs. IPMNs are further classified into branch type, main duct type, and mixed type, depending on the involvement on imaging. Due to higher rates of malignancy for resected main duct IPMNs, these typically will undergo resection, with branch type IPMNs typically undergoing surveillance because they're common, high prevalence in the general population, and yet carry a much lower rate of malignancy. Long-term surveillance studies have reported malignancy rates up to 4% at 5 years and 15% at 15 years. But most surveys will show, when all is said and done, less than 3% chance in your lifetime. So again, the Fukuoka guidelines from 2017, the 2 main criteria for malignancy, worrisome features, a group of imaging features such as cyst diameter over 3, solid nodule less than 5, enhancing nodule, enhancing wall, growth of the lesion of over 5 millimeters in 2 years. So again, these are the things we need to look for. We need to look for subtle findings so that we can intervene. But again, it's that balance of intervening on patients and not being overly aggressive. So let's do this. We've discussed a lot about IPMNs and some of the cystic lesions. Let's stop here and let's come back and start looking at some of those lesions and what we're looking for when we scan them. And with that, I'll see you in a few minutes. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.